Antiretroviral for. Okay. Hi, everyone. This is the Antiretroviral for Prevention webinar. We're going to wait a couple minutes to get a quorum, and then we will begin with our guest speaker, Dr. Patrick Sullivan. So just hang loose, and we'll be starting shortly. For those who are joining, this is the Antiretroviral for Prevention webinar. We'll be starting in a minute or two. Good morning and good afternoon, everyone. This is Ken Mayer from the Harvard CFAR and Fenway Health in Boston. And with my co-chair for the Antiretroviral for Prevention Working Group of the CFARs, Patrick Sullivan, I'm happy to welcome you to this month's webinar. Before we get going with our guest speaker, who is Patrick Sullivan, just want to make a few housekeeping announcements. Our next presentation next month, November 1st, first Monday at noon East Coast time for this series will be Dr. Dawn Smith, who's been lead project officer at the CDC around PrEP implementation. She'll be updating us on some of the issues that CDC has been thinking about. We will have the series continue into 2022, and we are looking for new speakers and topics. So if any of you on the call have data that you'd like to share, opportunities for work in progress or feedback from peers, please let Patrick and me know. We'd be happy to get you on the agenda. So without further ado, it's really a great pleasure to introduce our guest speaker today. Sorry, December 6th, not next month. Thank you, Alberto. That's right. We're an every other month function at this point. So next session will be December 6th. So it's a great pleasure to introduce our speaker today. Dr. Patrick Sullivan is the Charles Howard Candler Professor of Epidemiology at the Rollins School of Public Health at Emory University. Dr. Sullivan has really been a leading light in thinking about a lot of novel ways to approach HIV epidemiology and prevention with particularly innovative programs using the internet and other resources and geospatial mapping. So he's going to be sharing with us today some of the work he's done in developing AIDSview, PrEPview, and PrEP equity metrics. So Patrick, thank you for being here. You're muted.
Yeah, no Zoom call is complete without one person doing that. So I'm happy to be the one for today. Thank you, Ken. And it's great to see the list of folks who've been coming to the webinars, and appreciate you coming today. And today I want to try to sum up some of the work that our team has been doing around the sort of public accessibility of PrEP data, and that we released through AIDSview. And then I'll highlight some work on PrEP equity metrics that's been led by my colleague Aaron Siegler. And so I put this down with a lot of help from, I was thinking of the song, like I get PrEP data with a little help from my friends, but it's with a lot of help from friends and colleagues who I'll try and identify as we go through. So I'm just going to give you a quick overview of AIDSview, just 2 or 3 slides to set the stage for people who aren't familiar, but spend most of the time talking about AIDSview PrEP data, the data that we make publicly available and that we use on the site, talk some in more detail about the methods than we usually do, share some of the examples of how we try and process data at AIDSview to generate what we call insights, And then we also make all these databases available publicly, going all the way back to 2012. I'll show you where and how to download them. But I want to highlight some analytic uses of those data and just encourage you to think about your own analytic questions and if these public use data sets could be helpful, and we'll have some time for questions. So AidesView, since we started, was really just about making data widely available in different formats. The map that's sort of become our thumbnail, I guess, is AIDS prevalence data, but all kinds of data relevant to the epidemic, easy to access and locally relevant. So national data is one conversation, but prevention and treatment and care happen locally. And so we've really been trying since 2010, working with Gilead Sciences to drive down to those smaller geographic levels. So we started with data at the state level in 2011, HIV prevalence data at the county level, in 2011 the city level. In 2013, my colleague, our colleague Travis Sanchez, started working with cities to map continuum data at the zip code level, which I'll mention again. We added new diagnosis in 2011, hepatitis in a separate site in 2017, this is the PrEP data in 2018. And we've just launched a full set of 41 cities with city level continuum data at the city level and mapped to the zip code level. This is a protocol paper, and I just use this for two reasons. One, at the end, I'm going to sort of show you when I show you just a couple of things on the site where to get the PubMed or whatever, or EndNote or whatever file you use. But we're trying to really track how the data are used. And so we've published a protocol paper. And in the protocol paper, we use searches of Google Scholar by keyword because we didn't have a proper reference for AidesView, and looked at these different types of uses. And so one thing that we see increasing, which I'm really happy about, is the number of uses in academic publications where data are downloaded and analyzed, which are the blue bars. 2020 was about 2/3 of a year, I think. So we haven't updated this yet for 2020. And then a lot of people use the maps and visuals as well. So if you reference that protocol manuscript, it helps us track the uses. So today I'm going to focus on the PrEP data sources, and I'm trying to minimize the PrEP data sources and methods. So we started this work just because there had been this rapid increase at the beginning, which we'll see some more about, of people on PrEP, and CDC estimating that there were 1 million or more people who are at risk and could benefit. And when we started this work, the number of PrEP users had already increased from a very small number in 2012. But we knew already that PrEP use from sort of records, like institutional record databases and surveys, that PrEP use really varied across different sexes, age groups, and geographic regions. So we set out to get a really population-based data source. It's one of our sort of principles at AidesView is to try to use population-based data. And in March 2018, we launched the state-level data and interactive maps expressing the numbers of PrEP users and then PrEP users and rates per 100,000, which is just sort of a prevalence of PrEP use. And then in April 2020, we added county-level data on PrEP, which is important in light of the Ending the Epidemic initiative, but also just in light of the idea that all prevention is local, and the more granular we can get with these data, the more useful it'll be for prevention. And the data are currently available at national, regional, state, and county levels through 2019, and we'll be releasing 2020 data shortly. So in the county level maps, we have these indicators of the numbers of PrEP users and the rate of PrEP use yearly, overall by sex and by age. And I'll show you a little bit later. You can also display them alongside with sort of maps, one on the left, one on the right, with social determinants of health to try and see those patterns of relationships. I'll also show you where Aaron Siegler has quantified some of those relationships. So the data source for this, without putting everybody to sleep behind their muted videos is just to say that it's sort of a unique agreement. One, because we're sort of doing this in cooperation with Gilead Sciences, and Emory compiles the data, but part of that agreement was to be able to re-release these data at these geographic levels for public health uses. And so it's these data are used for a lot of proprietary purposes and typically with publication agreements, but the re-release, I think, was something that is not common, and we really appreciate our colleagues at Gilead who help facilitate that. It's important to say that no one knows how many PrEP users there are in the United States. The exact number is just unknown. And so I'm going to talk to you a little bit about how we try and get as close as we can to that unknown quantity. And of course, this is just because there's not unified medical records or pharmacy records in a governmental sense. And so we got to sort of put together a puzzle. So we're currently using Symphony Health, which is an open sample of data from pharmacies. So we're talking about 80% of the commercial pharmacies, includes also hospitals, outpatient facilities, and individual physician practices that have dispensing. And the physician practices also contribute data on diagnosis and procedure codes that are part of the way of sort of validating whether prescriptions are, okay, I'm sorry, I saw somebody was having trouble, whether the prescriptions are PrEP or for treatment or post-exposure prophylaxis. We use a validated algorithm, which I'll show you just a bit about in a minute. And as always, we apply data suppression rules so that we don't indirectly identify, for example, a very rural county with a single PrEP user or 2 PrEP users. We have rules that sort of prevent indirect identification or sort of stigmatization. So in terms of the validation algorithms, I want to first acknowledge that this work really was done by Robert Chino Mera at Gilead, and then with great work by Don Smith and Nathan Furukawa. And the idea of this is just to look in these pharmacy records for any indicator of PrEP. Let me see if I can have a mouse here. A pointer. Let's see what this does. Spotlight. So any users of Truvada are identified in the data set, and then there are a number of exclusionary elements. So we would say if someone's prescribed, and again, this was Truvada for the algorithm at the time that it was still branded. We now would incorporate generic and are incorporating Descovy as well. But if someone is prescribed this medication and has any indication of HIV infection, then we would say, well, they're not a PrEP user, they're likely using this for treatment. If they are using any other antiretrovirals with the Truvada or generic equivalent, or if they have prior periods of exposure categorized as part of PEP, if they have any periods with no diagnoses or procedures associated with them, or if there's a prior diagnosis of chronic hepatitis B, which could be another indication, or any concurrent or prior use of chronic hepatitis B treatments. And so what Nathan Furukawa and Don Smith and colleagues did was validated this against medical records. Dr. Furukawa reported an evaluation of this in a New York City health system population, and there was another validation done in a sort of community health center, LGBT health center, that is pending publication. So the data methods here, the idea is to provide reliable and consistent metrics for PrEP users at the county and state level. We know, as I've already alluded to, that the actual number of PrEP users is higher, one, because the data set only contains 80% of the pharmacies, so we're missing 20% there. And then some of these records don't have the clinical data to be able to determine whether that prescription for the drug was for treatment or for prevention. And if we don't have those data to those procedure codes or diagnosis codes to exclude those treatment indications, then we conservatively assume that it's not a PrEP use. So what these data are well suited for is public health research and planning purposes. So monitoring progress, assuming that these biases are relatively constant over time, It's useful to compare levels of PrEP use among counties, states, and regions. Again, assuming that the kinds of biases we're talking about, which is some missing data, are not substantially different between geographic areas, and to inform public health planning. So when we get the data, and this will become relevant to the discussion of county level data, we get the data as what are called ZIP3s, which is ZIP3 is just like in my home in Atlanta is in 30329. So I would be in the 303 ZIP3 along with 30322 and the other sort of 99 individual zip codes. So it's an aggregate of ZIP3s, but those aren't uniquely contained within county lines. So we used census data resources to crosswalk these and allocate out PrEP users in the ZIP3 into the constituent counties using population weights. And then the other thing that we do is start with what we call raw PrEP data. Raw PrEP data is just what we get out of the SHA database. And it is consistent. It's very conservative. It's just the number of people who we know were prescribed. It's a minimum number, and it's available at the county level. And that's what we use early on in our sort of PrEP dissemination. We also have what's called adjusted PrEP data, which just says we know on a state-by-state basis how many people are missing clinical data. So if we infer that the proportion of indications in a state for those who are missing that clinical data was similar to the ones who had clinical data, we can sort of weight that up and say, if the clinical data weren't missing, the adjusted PrEP data are our best estimate of what that would have been, or our adjusted estimate of what that would have been. And then finally, we know that 20% of the prescriptions are filled at non-participating pharmacies. And so we can also upweight for that. So we sort of give you the information and the choices about these, that this middle column is really available at national, regional, state, and county level, and the others are available at county level, and you could sum them up to other geographic areas. So just to sort of put the fine point on this, we start with a Symphony Health data set. We use an algorithm to determine what's your PrEP. We crosswalk from ZIP3 to county, and then add upweight for the missing clinical data, which is state stratified, and then add for the data that's not received county, and then suppress at the county level for low numbers or low denominators. When we talk about the sort of raw data set, we will just go crosswalk to county and then suppression. And then finally, the sort of best estimate data sets also account for that 20% missing pharmacy data. So you have a few options depending on what your application is. We've published the methods for this for both all the metrics we're going to be talking about today in Annals of Epidemiology, both for the county level estimation and Aaron Siegler's article about the PrEP to need ratio and the sort of some of the insights. So at HCU, with all of our data sources, what we try to do is get the data. We're putting them out for people to use in their own analyses. That's a primary goal of our work. But we also try to generate what we call insights, which are sort of what catches our eye about the data. Here, we're largely focused on health equity, and you'll see that focus through what I'm going to share with you. So we'll identify a series of insights, and then we translate them in different ways. We definitely want to reach colleagues like you who are interested in using these data for analyses and doing policy work and serving as experts. But we also want to be able to speak to local planning bodies or people who are interested in PrEP in their communities. So for the 2019 data, which are our most recent available, we would just sort of point out using a common scale between the two years that just between 2018 and 2019, the number of PrEP users grew by 20% in the US. We'll look a lot more at time trends. That 93% of all PrEP users in 2019 were men and 7% in women, despite the fact that 18% of new HIV diagnoses occurred in women. And so their women's PrEP use really wasn't equitable to their epidemic need. Another way to think of this is there were 7 male PrEP users for every 1 new diagnosis among men, but only 2 female PrEP users for every new diagnosis among women. And this infographic sort of gives you the insight to the PrEP to need ratio that we'll talk about later. There's also this sort of gap for younger people, 24 and younger, who accounted for more than 1 in 5 new HIV diagnoses, but only 14% of PrEP users. By region, this is a pattern that we've seen that's been persistent. If you just look at the left box in each of the regions, this just shows the rate of PrEP use. So out of the gate, you can see that the Northeast has a higher rate of PrEP use than the other regions, and the South has the lowest rate. And then the number in the right box is the PrEP to need ratio, which is just dividing that number of PrEP users by the number of people newly diagnosed. So that same metric we saw in the previous infographic. And what's important to note here is in the Northeast, you have 11 people taking PrEP for every 1 new diagnosis, whereas in the South, there's only 4 people taking PrEP for every new diagnosis. And this PrEP to need ratio is an equity indicator. We would like to see that by region, by sex, by race, when those data become available, by age, that there's an equity and that the communities that are at greatest risk for acquiring HIV have the highest levels of PrEP use. But at every step along the way, one, you're going to see that that's not true when we use PrEP to need ratio, but also that PrEP to need ratio is an important indicator of, it can be used to illustrate the impact of policies, or conversely, that policies can likely impact that inequity. In 2019, we focused a fair bit on counties and just trying to highlight these different things of PrEP, different indicators of PrEP users versus PrEP to need ratio. So here are the 5 counties with just the highest rate were New York, San Francisco, Suffolk County, Kings, and Broward County. Those are just the highest rate of PrEP users. But when we factor in the epidemic burden in those communities, the highest PrEP to need ratio, that's that sort of PrEP use that should be higher as infections are higher, has a different set of counties. So Boulder, Colorado, for example, has a lower rate, but also has a much lower rate of PrEP of HIV diagnoses. New York County and Manhattan stays in that list, but Saratoga County. So you see some smaller places that are doing quite well with their PrEP to need ratio relative to their PrEP use relative to their infections. Overall, between 2018 and 2019, I mentioned there was a 20% increase in PrEP use across the US. And the 5 states with the largest increase were Puerto Rico, Montana, Florida, Wyoming, and Arkansas. You can see they significantly outpaced. In some cases, this was because of relatively low rates in 2018. And then we look at the county level just to show you the breadth of the extent of PrEP implementation and uptake, how widely that varies by county. The average rate in all the EHE counties was about 134 users per 100,000 population. But in San Francisco County, it was 644 was the maximum. And in San Bernardino County, only 35. So almost a 20-fold difference in the sort of rate of PrEP use among counties. We also did some modeling work to ask in 2018 how likely the EHE jurisdictions, county jurisdictions, would be to reach the national HIV/AIDS strategy goal. The sort of pre-EHE goals had set a goal of increasing PrEP use by 500%. And in 2018, we estimated that 94% of the counties had either already reached or would reach their NHOS goal by the end of 2020. So I want to show you 2 applications of these data, and I hope I'm going to pop in and see if there are questions to answer in this part, and feel free to put them in if you have them. But I really hope people are thinking about, what are the questions in the place that I live, in the place that I work, in the communities that I serve, that we need to answer to make these priorities and to advocate for them, and how could these data be useful in analyses? And so I'm just going to give you 2 examples of how we've used these data. I'll acknowledge some other folks who've done analyses with them at the end. So this is a paper where we describe the methods for county estimation with the ZIP3 and the sort of crosswalk, and really focus on the EHE jurisdictions, looking at all these metrics: PrEP users, PrEP to need ratio, PrEP to MSM ratio, and then did join point regression to look at the sort of estimated annual percent change or the trajectory of PrEP use and model those out relative to the NHAS targets. So this is the data sort of setup. Sorry. This is the data setup where we look by sex and by age groups at the numbers of PrEP users, at the PrEP to need ratio for that county overall, the PrEP to MSM ratio, so this is per 1,000 MSM, and the PrEP use to PrEP eligible MSM using metrics and methods developed by Jeremy Gray and Don Smith. And this gives you sort of an indication of it's per 1,000 to show the whole range, but like 88 per 1,000 would be about 8% or 9% of the PrEP eligible men in Maricopa County were using PrEP as of 2018. And this goes county by county and by age group. These graphs just illustrate the change in the prevalence of PrEP use. And the stars here are in the join point analysis. The join point analysis will identify inflection points where the rate of increase changed. So we had, for example, in New York City, 142% increase year over year through 2015. And then after 2015, that rate of increase that got lower, that slope dropped. And so the join points identify that. And we go through each region and all the EHE counties. And you can see again where those join points happen. Here, San Francisco County is the real standout and had that same sort of transition from an average of more than doubling every year up through 2015, but it's hard to sustain that pace. And so in the 15 to 18, that dropped to about 20% year over year. And this also helps us pick out counties that are outliers to the good or bad within a region. So here, East Baton Rouge through 2016 had an estimated annual percent change of about 50%, but starting in 2016, assumed a new trajectory of more than doubling. And so this sort of positive or negative deviance leads to questions about, what's going on there. Let's, if you're in a state or you're in a jurisdiction, let's contact them and see what those best practices are, what made that change, and can that be implemented elsewhere? So the conclusion of this was that through the 2018 data, 24 of the 50 EHE jurisdictions had already met the goal for a 500% increase in PrEP during that period. 23 more were projected to meet it in 2019, and 3 were not projected. And I have to say, being somewhat involved in the discussions about the development of the indicators for NHAS, this 500% increase, I think, was seen as a very ambitious goal at that time in some of the discussions. And so amazing to see how well that it was actually doable. And then I want to highlight this work from Aaron Siegler, who looked at all counties in the US and classified state policies as to whether they had a PrEP drug assistance program or Medicaid expansion, the PrEP users, the PrEP prevalence, the PrEP to need ratio, and just describing those county characteristics and then using multi-level modeling to look at the associations of some of the characteristics of policies and the change in PrEP. So this is sort of the data layout, which is similar to what we saw before, which is stratified by age and sex, and the number of PrEP users, the prevalence, the new diagnosis, and that PrEP to need ratio. Just emphasizing again, as we saw in the demographics, that the fact that the PrEP to need ratio in men is 6 and in women is less than 2 means that that women are sort of under engaged in PrEP care relative to their epidemic need. And we also saw an infographic that highlighted this for the less than 24-year-old age group, which you can see here. And so touching back on AIDS, we would look at these data as probably everybody on this call is used to looking at them and process that and make sense of those. But we also recognize that people who are involved, invested, and engaged and active in HIV prevention and education process information in different ways. And so for some people, the data makes really good sense in this table, but for others, use something like an infographic, boils down this data and makes it more conceptual and quantitative. These are the data now stratified by states that had PrEP DAP did not have PrEP DAP. So if we just jump over to that PrEP to need ratio and say among the states that had a PrEP DAP program, the PrEP to need ratio was nearly double what it was in the states without a PrEP DAP program. And in the states that had Medicaid expansion, the PrEP to need ratio was more than double. So you can see sort of in the descriptive data that unless something's confounding this, that these state policies are really associated with increased appropriate use of PrEP. The other things indicate things that were put in the model were the percent uninsured. So here you see in the top set that the higher percent uninsured in the state, or sorry, in the county, the lower the sort of equitable use of PrEP was, threefold in the counties with the highest quartile of uninsured people, that the higher concentrations of Black residents were associated with lower equitable use, and that higher percent of residents in a county with a bachelor's degree or higher is associated with more. So these are social determinants of health, but also indicative of sort of health inequities based on race, and in some cases policies that have the effect of excluding people of color from care. And then in the regression model, these are now going to be rate ratios. And what I'll point out here is the last two rows, which is that in places that had Medicaid expansion or PrEP DAP versus none, the sort of rate ratio was 22% higher. And for those that had both, the sort of appropriate PrEP use, this is regressing the PrEP to need ratio, that sort of appropriate and equitable PrEP use was almost 60% higher. So I think it's you know, this sort of area level data that suggests the association of these policies, and you know, the hope is that this can be used again, just as we translated the infographics from the tables into sort of which groups are inequitable. This needs to be translated and said, like, if we took these steps in our state to provide these programs, what other states have found is that, you know, the sort of equitable use of PrEP goes up by 60%. So I'm going to wrap up just showing you some other resources. I mentioned that on the website, you can actually compare things like rates of using PrEP at the county level to those social determinants. And I think this is important contextual information. So if you find, you know, a county or set of counties where the rate of using PrEP is low, but the level of health insurance is quite high, you may want to look in other directions. And I think this provides just information about the context of who needs to be reached when PrEP uptake needs to be increased. The PrEP Locator is a national directory of PrEP providers in the US. It was developed, Aaron Siegler led the protocol for this. MAC AIDS Fund funded this, and we hosted it on AIDSview for a number of years. It's now managed by CDC NPIN. But one of the interesting things to do is to be
Patrick, you're frozen. For those on the call, Patrick has some technical issues, so he's logging out and hopefully logging back imminently. Welcome back.
Sorry about that. Can you see my screen?
Yes, joys of technology.
Yeah. So I'll sort of move on. We have local data profiles. I'll show you some examples of these at the end. And then we summarize a lot of our prep materials in what's called a deeper look, which is a combination of summaries of these infographics, summaries of the metrics, but also sort of guest blogs with different people who've done the work and used the data. And so here, I've mentioned Aaron Bisolo, Ojikutu, and Yusuf Ransom have used these data, and so we highlight their work, and you can learn more about that. The infographics and video, we've shown some of those. I really want to get to the downloadable data sets, and I'm going to show you where all these things are if the internet behaves. But I mentioned that you can download these at different geographic levels, either in the adjusted format, in the best estimate format, or in the raw format. And you don't have to register to use them. You can just get them and download them. They go all the way back to 2012. And as we put up new data, we always put up the corresponding data sets as we put them up. I just want to show you a couple things. Ken, can you see the screen that has AIDS-U on it now? The website? No, you might be muted.
Sorry, just see the hyperlink. No
Yeah,
data.
I may need to share here. All right.
Maybe you can click on it.
Okay.
There you go.
Okay. So this is just an example for New York State. And what I wanted to show you was that you can access the data and calculate these things, but we have all the main highline things like HIV prevalence, new diagnoses. And then for PrEP, we have this distribution by sex and age, which is what we have currently available. A graph of the number of users going back to when the data started, and the PrEP to need ratio to when the data started. So those are sort of pretty easily accessible. Go back to the slides. I want to emphasize that CDC has also stood up in this last year the AHEAD dashboard, which shares some features of AIDS-U, but is really focused on the ending the epidemic jurisdictions. And so they have an indicator for PrEP coverage and also map this out. And one of the things that they do is show them alongside the 2025 goals and allow you to compare one jurisdiction to the other. So if your primary interest is saying, like, how is Chicago doing relative to New York, you should think about the AHEAD. I put the URL down here. The AHEAD dashboard, which has data on PrEP coverage as an indicator. So I will sort of end by just saying, like, we produce these data because we want people to use them, and we'd love for you to help. You can sign up. You may have seen when I was signing in, it asked me if I wanted to get emails from AIDS-U. We don't spam you, but we let you know when there are new data available. Share those with your networks. There will be a recorded public webinar for this. We have recordings of the AIDS-U webinars. You can also, on Twitter and Facebook, we put out those sort of one panel, one message at a time infographics, and you can share those during through social media. Use the AIDS-U PrEP data in your work or in your analyses. Acknowledge AIDS-U through citing the methods manuscript, which I mentioned. But also, if you email us, if you email me, or if you email just AIDS-U@AIDSU.org and tell us how you've used the data, we do these AIDS-U Q&As where we can get a little deeper context and get your message out to tens of thousands of users and highlight your research if you've used the data. And we are always looking for research to highlight. And if you really want to do analyses and you don't quite see how the data we have can support that, you can also, again, email me or email the help@aidsvu.org, and somebody will get back to you and see. We may have some data sets that we don't put out publicly because we don't think they're that useful to people in general, but we may have them. I'm just going to show you, switch shares one more time and show you two more things that I mentioned. So one is how to get to these data is under tools and resources. There's a tab called data sets. And then you can see that for every year going back to 2012, there is, PrEP to need ratio, new diagnoses, et cetera. And again, you don't need to, so this is at the national level, at the regional level, at the state level, county level, and we have city level data. And all these are just free to download. You don't have to register. We'd love it if you find it useful and acknowledge it. That's great. And then the other thing I want to point out is all the way at the bottom where it says citation. We actually tried to provide details about all the methods. So if you're using these, this is where you can get into the nitty-gritty of how these are calculated. And also at the bottom, you can export the citation to cite this into any of the reference manager software. So I think the last important thing that I have to do is to show this slide and say thank you. I'm sorry, what's next? We will update to 2020 PrEP data this fall. Next year, we'll be changing our data source to IQVIA data, and we'll do crosswalking comparisons and make all those data sets available from both vendors going back. In 2022, we'll be adding race data. This, if you, for knowing many of you as I do, probably as I was showing age and sex data, you were saying, what about race? That's really the story here. And so these data sets have a lot of missing race. More than 60% missing. And so some folks who work with these data display those and weight them up and just say, let's assume that the 65% missing has the same race distribution within a state as the 35% reported. And we haven't been comfortable doing that, but we're working on methods to use other data and imputation methods to get that more complete. And then we'll release that next year. I really want to acknowledge CDC's work in this same space. They've been working with IQVIA data. They have a different algorithm for classifying PrEP use than we use at AIDSView. They use one developed at CDC. We use one developed at Gilead. So if you're comparing, their data products and ours, and you see a difference, part of that may be because they're using a different data set and they're using a different algorithm, and just understanding the ups and downs of those. And the last thing I want to mention is the VIEW Fellowship. We actually just closed applications, but this is an invitation to submit an idea to do an analysis using the PrEP data or other AIDSView data or HEPView data, and it carries a $10,000 personal fellowship. And the expectation is that you'll use some of the data found on AIDSView to ask an important question and answer it. It can buy you some protected time or just be a personal, sort of stipend. And we'll open that again next year. And if you get on the AIDSView mailing list, you'll get a notification. But we're excited. We had a really robust applicant pool, and we'll be awarding our first 3 AIDSView fellows sometime this fall. So here's the important slide, which is that I've mentioned Aaron Siegler, who's really been a partner in this work, but also Signal DC, who makes the website and makes all the infographics, Gilead, and other colleagues who've worked on these methods in the site. And just thanks to Ken for the opportunity to summarize all this, and happy to answer questions if folks have them. And I see there's some in the, Ken, I'll let you, if you have other questions, or we can just take these.
Yeah, no, Patrick, this was brilliant. Yeah, there are 3 great questions in the chat, so should get us going. So one was about looking at AIDS view in relation to PrEP view in relation to COVID vaccine and any kind of joint mapping. Another question, Ken Ho, could you discuss limitations of the PrEP to need ratio, especially areas where HIV incidence is low and greater variability in subpopulations? And then what about more granular detail about tracking individual trajectories? You know, people go on and off of PrEP, but maybe frequent flyers at different sites. So what can you track about that?
Sure. Thanks for these questions. So with respect to the COVID vaccine uptake, I think it's a really interesting question. I think I know that there are other sites who have done similar kinds of mapping for COVID cases and I think vaccine, but the side-by-side comparison is an interesting one. And I think I just don't know offhand the extent to which the raw data for the vaccine uptake at the county level is downloadable and available. But that's certainly an interesting thing to do. And obviously COVID has had impacts as well on PrEP, which many of you are studying and are experts on. So I think understanding that relationship is a good idea and probably outside the scope of our AIDS site, but what we try and do is put these data out in a way that if someone has a great idea, which Jingjing has a great idea, that the data are available to be able to download and implement those. So that's a great suggestion. So the PrEP to need ratio, because of Ken, I really appreciate this question because of the nature of this. That the smaller you get, either in terms of smaller geographic areas or in terms of dividing into subpopulations, that ratio measure is just going to start to behave a little bit erratically. I just say even down to the county level, most of the counties in most of the regions have sufficient diagnoses to make an estimate by our suppression rules. But one of the things that will happen in AIDSView's presentation is where there are too few diagnoses in a geographic area, that either the denominator of that PrEP to need ratio would be suppressed, meaning if there's less than 5, then we wouldn't present those data. We just call them suppressed and wouldn't calculate a PrEP to need ratio, and those will just show up as not reported in the map. Or if the number of PrEP users is too low, that would also trigger suppression. So I'd like to look at this more in light of your question, but I think the principle that at lower numbers of numerator or denominator, that these are going to sort of be more unstable, but feel somewhat confident that the extremes of that, where 2 or 3 more PrEP users might really change the PrEP to need ratio, a lot of those will just be suppressed in the data and probably not presented. And then in terms of the individual level data in the data sets, yes, age, sex, and prescription data are available. Race data are available when it's reported, but there really is I think there's kind of everything else. So there are dates and the sort of number of pills in the prescription. And there has been some work done about this. Farah Muhana, who's acknowledged here, has worked with some of those data to follow the sort of cycling on and off. And we don't report these as new users per se. We report these as people on PrEP, not necessarily as PrEP starts. But you're right that that's composed of some people who may be starting for the first time and some return users. And that could be interesting data to make available in these data sets. So I would say Aaron Siegler has done some of this work with Walgreens Pharmacy. Farah Muhana has done some of this with the SHA data, and I'm happy in follow-up to send you some links to ask Alberto or Mark to distribute some links to some of those papers. But you raise obviously a really important question, and I think what we haven't gotten to, but I think is an important thing for someone to get to, is what are the correlates of those sort of individual PrEP trajectories cycling on and off, and are those related to region or to insurance issues or to other demographics that we could use to try to improve that. So a great question that we haven't addressed.
Other questions? Let's see.
Yeah, Jingjing pointed out that we do have a COVID. We actually used our view tag in a national probability sample of U.S. households for COVID view, and Jingjing helpfully points out we have a COVID view site, and so it also could be that those COVID view data might relate to HIV or STIs in terms of this idea of whether risks increased or decreased during the epidemic.
Patrick, you've done such a great job with the PrEP to need ratio, and you've highlighted the role of disparities. Have you thought of looking in the same geographic locations at the PrEP to need ratios to create some kinds of disparities indices? Because some places may have more, a greater level of disparity, so that the PrEP may not be reaching within the geographic location populations who might most benefit.
I mean, it's a really great question, because I think what you're talking about is we sort of were suggesting that comparing, for example, male and female specific PrEP to need ratios, or 25 to 44 and 15 to 24, that comparison is essentially an index of disparity. And so I just have to think about, in my epidemiology hat, the sort of ratio of two ratios as an indicator. But I think that your intuition is exactly right. I just want to think about what we would call it. But trying to express that to essentially express the magnitude of the disparity, as opposed to expressing the two and saying you can see that one's higher than the other, I think it is, as a ratio-based measure, makes sense.
Well, and comparing jurisdictions, because
right,
two jurisdictions may have the same aggregate PrEP to need ratio, but one may have disparities, and the disparities may be in the populations where you're most concerned about increasing PrEP access.
I think that's a really insightful comment, and I think when we've been working on the race data for a long time, just because of our own, like when you're missing that much data, I just feel very cautious about it, and it's such a critical issue that we want to get it right, but it's such a critical issue that we don't want to be overly cautious. But as we come out with it, I think that rethinking how to compare these inequities, because there are inequities by sex and there are inequities by age. The inequities by race and inequities by race, perhaps especially among women, but by race, by sex, we're going to need to find ways to quickly communicate all of those and their relative magnitude. So I think what you're suggesting has a lot of traction. And if we use that, we'll come knock on your door and look at them together. But it's a really good suggestion.
Sounds good. Random question.
Random question for Ken.
You have an estimation of when we will have mRNA vaccine for HIV? Above my pay grade. I mean, I think Moderna certainly has started trials in humans. So I think people are looking at the concept, but you still have some daunting mucosal immunology to contend with about where the virus lands and what kind of immune responses you need. So there's lots we need to know. Anybody else on the call is welcome to venture a guess, but
I think there have been some historical early phase exploration of mRNA vaccines quite a while ago. I could be mistaken, that didn't get past some of the early thresholds, but certainly probably the technology is better, and I think people's confidence in it is better now. And some of these companies that now have substantial capital because they've sold a lot of COVID vaccines they might also be able to. Oh, Colleen says a few to enter phase 1 trials imminently, so a long way off.
Yeah.
That seems to be the story of HIV vaccine. I mean,
yeah.
It is a pandemic, but the timeline is not as compressed as it was for COVID. That's for sure.
I think the PrEP work still has a long half-life. Yeah.
That's right.
Yeah. Where there's a will, there's a way.
That seems like you're chairing this, but that feels like a really nice way to end. Unless you have more.
If there are other burning questions, You know how to reach Patrick and how to reach PrepView. Really great, incredible resource that you and your colleagues have developed, and really impressive work you've shared with us today. So thank you so much, Patrick, and thanks everybody for participating. To be
Thanks for
continued.
the opportunity. Have a good afternoon, everybody.
Care.